Good morning, I'm Dr. Theresa Pazionis, and this is Dr. Mohammed El-Hashimi, and we're going to be taking you through a prone lateral workflow using the Excelsius GPS. So the first thing to note is that we've already established navigation. You can see here that we have the navigation fiducial, which is a quad application, and then we have the surveillance marker, very important for safety and for checking your landmarks. We've used a preoperative CT workflow, given this person has donated their body to science, and then we've merged it with an X-ray workflow that we're going to use. So we can see here that we have what we call the chicken foot navigation probe, and that's going to be used to localize our level. So we've selected level L23 to demonstrate our prone lateral. So you can see here, if we go up top, I'm on the spinous process, and that's just kind of a navigation safety check. And then we've already localized where the 2-3 level is. And it's very important to not stand in between the robot and the navigation camera, so you can actually see what you're doing. So what we're going to do is position the patient prone. This has a couple of advantages. Number one, the patient is in an anatomical position to maximize your lordosis. Number two, it's a single position as opposed to a dual position surgery. So if you need to do a revision, which oftentimes will happen over top of a construct where you have proximal junctional kyphosis or degeneration, it's very easy to do this with more efficiency, hypothetically less blood loss, and the reduction in radiation, given that we're going to be using robotics. So initially, I'm going to start proceeding using a 15-blade scalpel to make my longitudinal incision in line with where I've planned navigation. And this is a trans-psoas approach. Generally, we use a neuromonitoring setup, which is attached to the patient's limbs, which you would be using in a live patient. That being said, there's also a navigation that you can use that attaches to the retractors.
Theresa, do you want to tell us a little bit of how you plan the incision and if there's any?
Okay, so this is a longitudinal incision, which is underneath the ribs and in line with the L23. And
so you go from the
it's
front,
going retroperitoneal, and I'm using finger dissection initially. Thank you so much.
Sorry, how do you plan it out? Like for lateral, sort of from the ALL to the posterior aspect, or do you finesse that?
Okay, so yeah, so initially what we're going to be doing is we're going to be anterior. So we're going to be anterior, but we're going to be posterior to the ALL, and it's very important that you try not to enter the retroperitoneal space. If you go too anterior, there's a lot of vascular structures anteriorly that you can hit, so that's bad. We are going to be actually turning the bed slightly away from me to facilitate the dissection, so if we could do that now, that would be great.
Theresa, I don't know if they had the bed positioner here, but do you use that?
Yeah, I do. So, I mean, I'll turn the bed away from myself when I do it. And you can see here that it's rotating to just give us a better angle. Okay, so you can either use a tubular retractor, or you can proceed downwards using a cob, which is what I'll do here. I'm at some bomb scissors, so I'm going to grab these. Okay, and I'm actually going to sit down for this part of it. Generally, I wear a headlight, but you can feel downwards towards the spine. And Mohammed's just going to come and have a look. So it's more of like a spread type approach. Okay. And at this point, I'm feeling the lateral aspect of the vertebral body. And we're going to use our navigation to confirm where we are. Okay, so if we're going to count, that's 5, 4, 3, 2. So we are immediately at our interspace, so that is the correct location. So what I'm going to use is the retractors now, so we can either use the sequential dilators or we can use the globus retractor, which we have right here. Okay, and we're going to measure initially. Thank you so much. Okay, and I'm going to use the... Okay. Just give me the chicken foot back. Thank you. All right. Okay, so this is navigated as well. I think you're just getting in the way of the camera. Okay. We're just carefully navigating this towards the disc space. Okay, so you can see that this is where we've planned it initially. All right, so there is, perfect. Okay, I'm just gonna take the pin, please. Just gonna place that through.
Theresa, do you have I see that you're in the posterior third right now. Is there a certain space that you like to dock, like in the 50-yard line or of the vertebral body, or?
So yeah, so I'm going to go at just immediately anterior to it. So I'm going to go at 2 right here because it's just going to help facilitate my angle, okay? All right, I'm just going to hit that in very, very slightly, just being mindful of not going all the way through and causing a neurologic element injury. Slightly more, may I? There you go. All right, great. So at this point, we're going to use sequential dilators, and then do you have the docking, please?
What length are we on that?
So we are at 90.
You can pass through the blue dilator. Right?
Okay, great. Okay, drop down. Okay, great. And this is the globus invasive retractor, so we're just going to pass that over top. Just being cautious. Okay. Can I have the expander?
Expanded.
Thank you. Okay, so now what we're going to do, I'm not sure if you guys can see here, is we're going to expand here and open the blades of the retractor to allow us more visualization. Because we've docked it proximally, expanding it distally is going to be key in terms of visualizing the disc space. Oh, perfect, thank you. Okay. Very important, again, to complete another navigation check. Can I have the locker, please? Yep, please lock it down. Okay, great. I'm just going to do another navigation check with the chicken foot at this point, just to make sure that we are in an optimal location. You can see here that we can, in fact, localize the disc space in an acceptable alignment, okay? Great. Okay, do you want to apply the shim? So Mohammed's just going to place the shim at this point. Okay. Yeah. So what you're going to do is you're going to put it here. It's not really. Yeah, it should be going there. It's not.
It'll go a little deeper before it's not.
Yeah, it's not going through there.
It won't go through there. It's going to slide down, and then it'll connect on that part.
Yeah. Okay, perfect. All right, sounds good. Do we have the light source? All right. So we're going to slide these on. And we can take out the guide wire at this time as well. Okay. Guide wire is going to be removed. All right. So I'm not sure if you guys can see in here, if there's a camera that can show us this angle. We can't? Okay. All right. So what I'm going to do at this point is I'm going to sit down. Okay. I'm going to visualize a little bit better what's going on. I'm going to take a cob, please. Okay. And then I'm just going to gently dissect anteriorly to the anterior border of the vertebral body. Okay. Can I have the navigated disc prep, please? The disc prep. Okay, so at this point, we've established navigation, we've established our lateral entry portal, and we're going to be doing the disc prep using the initial navigated probe. So you can see here that this is a cob. Okay. And that's the initial entry port right there. All right, so at this point, you can use a mallet to enter the disk space. Just going to drop my hand. There's a fairly large osteophyte that I'm trying to navigate my way around. Further dropping my hand.
Hey, Theresa.
Yep.
Quick question. I mean, it seems like you're a little oblique. Do you ever just push the retractor down to make it more?
Yeah, I'm pushing the retractor down. What I'm trying to do is get around the osteophyte here. So it's right there, but. Okay, nope. All right, just have to get that in again. So sometimes with a lot of osteophytes, you can actually face a fairly significant challenge with getting into the disc space. Yeah. This is kind of just getting in my way a little bit, so I'm just going to take this off. Okay. Okay. Mallet, please. Shoot. Yeah, so it's just not. Do we have a navigated osteotome? So just given that the cob is having a little bit of difficulty kind of entering, what I'm going to do is use a navigated osteotome. We don't have one? Okay, I'll try the curette. Navigate curette, please.
Navigate what?
The curette? Okay, wonderful, thank you. Okay, so what I'm doing is just taking down the osteophyte, and I can both directly visualize that as well as see it on a navigation. Okay, mallet. Okay, great. We've entered the disk space. So I think the teaching point there is that oftentimes you are going to have some difficulty taking down osteophytes, especially in these degenerative cases. But switching your instruments and switching your trajectory as well as using the navigation is kind of the key to making sure that that's effective. You can see here what I'm doing is dropping my hand to make sure I'm still in a safe trajectory and not going too anteriorly. And I'm proceeding along the planned trajectory of the interbody cage. Okay, great. And you're going to have tactile feedback as well, superiorly and inferiorly along the end plates. Disc prep is likely the most important part of this procedure in order to get an appropriate fusion. Do we have a curette, a larger curette? Okay, thank you. So we're now going to use the ring curette in the same trajectory. Okay. Okay, mallet. Okay. At which point we're going to use the ring curette to remove disc while in making sure that we're staying posterior to the anterior longitudinal ligament. Dropping my hand to proceed across the body. I'm also going to see if I can break through the osteophyte on the contralateral side, as that's going to help with our expansion, but ensuring that I'm not going too far because that can violate the nerve root. Okay. Okay. Pituitary, please. I'm now going to use a long pituitary through direct visualization. Okay. All right, do we have the trial, please? Thank you. Okay, so this is the initial trial that we're going to use. And again, this is navigated. And we're trying to use the exact trajectory that we had planned. Just to kind of enter. Okay, great. That's more the trajectory. Okay, continue. Continue. Dropping your hand and ensuring that you're following the appropriate trajectory is very important for these cases. Continue. So you're not in yet?
What's your finger?
It's okay. Okay. Stop.
Yep.
So you can see that we're kind of just getting in the way of the navigation here. Okay, and I'm going to proceed slightly more across that disc space. Okay. We've lost the navigation due to camera angle at this point, so what I'm going to do is I'm just going to slap that back. Okay, next. All right, so now what we're going to do is proceed with the implant. So this is an expandable implant. There's a couple of options available. There's a static and an expandable. Generally, the expandable does have a slightly tighter fit and end plate contact just because you're allowed to get a smaller implant and then expand it up. This has been recently proven with a biomechanical study through Globus. And we can see that we're following our planned trajectory again. Okay. Okay, almost there. Okay, so I think we have optimal placement of our cage, and we've noted that the position looks good. Now we can proceed to expand. Okay, so Mohammed's going to do that for me. Okay, so Mohammed, just click it in.
Teresa, quick question.
Yes.
Before expansion, I mean, I know this is a cadaver situation. Would you get a fluoro just to confirm, like
I would, yeah.
nav-
So if we had fluoro available, which we do, you do an AP and a lateral shot before any expandable cage or any hardware placements. And following that, you can expand and take your shots.
Great.
So generally when I expand, I actually do it under live fluoro. Try and minimize that, but I think it's a little safer. Okay, so you can see that it really does go far in before it engages. Okay, so turn it. And then we can take a fluoro shot if you want, just to kind of see the difference with the expandable. So I don't torque it out entirely. What I do is when I do this under live fluoro, you see where it looks like and then proceed accordingly. Yeah, let's take a shot. So what I'm gonna do is I'm going to drop the cage, and then we'll take 2 shots, 1 AP and 1 lateral, just to see what it looks like. Okay, so we're gonna step back from the fluoroscope and maintain radiation safety, and we're gonna come in and do that. Okay, so you can see that that's optimal positioning of the expandable cage on the AP shot. Okay, and then we're gonna take a lateral. Can't quite see it, so readjust that. Okay, and that's where we had planned the cage. It's in a reasonable position. Not too far into the canal, but I'd like a better shot before we... Yeah, okay. Yeah. So now what we're gonna do is expand it, and we're gonna see the difference on both the AP and the lateral shots. Yeah, so first we're gonna take the AP shot, fully expanded. And this will torque out. It's a gray handle, so what you're gonna feel is 2 clicks. But that being said, you don't have to expand it the entirety of the way. It just needs to be per your goals surgically. The light source is constantly coming out, but that's okay. All right, so I'm gonna step back. It's expanded. See what that looks like. Okay, and you can see that the cage is expanded somewhat. With a fractional kind of deformity correction at that level. If we maximally expand it, 1 shot, please. Okay, that's about all the cage is going to give us. And that's the completion of our lateral interbody cage. At this point, because we're in the prone position, what we can do is we can put bone graft in through the tube as well, and then what we can do is we can start with our posterior screw placement. Okay, so we're gonna remove this. Take that back. Can I have the back slap, please?
Theresa, yeah, in the regular sort of workflow, would you put the screws in first? With the cage expansion, do you think it might shift your registration a bit?
So no, I don't. I put the cage in first, and then I follow with the screws.
And you don't respin or anything?
I'll respin.
You respin, okay.
Yeah.
Yeah. Another question, this is 2-3. So, again, would you do it any differently at 3-4, 4-5? I mean, like a more anterior sort of trajectory at the beginning?
So, yeah, I generally do, because at 4-4, 4-5, and 5-1, you want more lordosis. 5-1, you're generally going to be doing an ALIF. If you're doing a prone lateral, obviously, you want to make sure that you're maintaining adequate lordosis. You get some of that from positioning and some of that from cage placement. 2-3, it's less key to do that, and you can have more of a central cage placement, as we've demonstrated here.
Okay, great.
Okay.
Theresa, again, thank you so much for doing this demonstration. Really, we all learned from your expertise. One quick question I had, when we do the in lateral position X lifts, right, or E lifts, whatever we call them, sometimes you place the initial retractor even more ventral because of monitoring changes, right?
Correct.
I noticed that you did exactly the opposite, actually, that you started very posterior and kind of worked your way ventral, which kind of makes sense too. But do you do the same maneuvers there, or is it for you different?
So I generally use neuromonitoring while I do it, and then I look around and actually see if I can see the nerve root, but I also will use the positional monitoring from the retractor, with the invasive retractor. So one of the risks of the procedure is that you can have neurologic injury. It's pretty rare, but it's something I think you have to monitor for. Generally, I find this workflow is a little bit better for me. With the anterior placement, I just find it's more awkward to kind of just raise your hand and then lower your hand versus just proning the table and having more of a posterior to anterior workflow.
Yeah. And then two more questions. The shim, do you have it also, in a dorsal position in relation to the patient, or do you do the opposite for this procedure?
So this is the opposite for this patient.
But no, in your clinical workflow, do you do the opposite too?
You can, but I mean, I think as long as it's docked in bone, either way is acceptable.
So that's a freedom, a choice for
Correct.
you. Okay, great. Thank you.
Okay, thank you.
Great. So